Text 3. Anxiety and Bipolar Disorder. Anxiety is a normal part of everyday life. Anxiety acts as a signal which motivates us to improve performance and alerts us to impending dangers. Yet anxiety can get out of hand. When this happens, the normal warning signal mechanism of anxiety becomes a psychiatric symptom. Anxiety symptoms occur in a group of disorders characterized by free-floating anxiety, panic disorder and generalized anxiety disorder, phobic anxiety, specific and social phobia, traumatic anxiety, post-traumatic stress disorder and acute stress disorder, and obsessive-compulsive symptoms. Each of these disorders includes features of symptomatic anxiety, such as high levels of bodily arousal, excessive worries about potential danger, and avoidance of feared situations. The disorders differ in the degree of preoccupation with body symptoms, the focus of worry and the extent and type of avoidance. Many clinicians and most consumers and their families are unfamiliar with the differences between these diagnoses and tend to view anxiety as a general and overall symptom. This is particularly true when an anxiety disorder occurs along with another illness, and when the latter illness is the focus of treatment. Nevertheless, the different anxiety disorders have different ways of working in the body and also have different responses to different kinds of treatment. Anxiety disorders are the most common psychiatric conditions in the community. These disorders are often trivialized, in part because of their high frequency and in part because anxiety is a normal part of life. However, anxiety can become debilitating. Anxiety disorders have been shown to cause difficulty in people's ability to function in their daily lives and can affect quality of life as well. Experiencing a major depression greatly increases the likelihood of having an anxiety disorder. When an anxiety disorder is also present, depression is more severe and is more likely to fail to respond to treatment. The presence of panic attacks increases substantially the risk of suicide in a depressed individual. Other debilitating anxiety disorders, including social phobia, obsessive-compulsive disorder, and post-traumatic stress disorder, are also commonly seen with depression. Anxiety disorders appear to be common in people with bipolar disorder as well. Yet anxiety is rarely discussed in the medical literature on bipolar illness. Clinicians and people with bipolar disorder may well be unaware of the potential very negative consequences of this seemingly unimportant complication. Most of the existing literature focuses on panic disorder and obsessive-compulsive disorder, OCD, both of which are greatly elevated in bipolar illness. What is known about how anxiety exerts its negative effects in people with bipolar disorder? One study looked at differences in how individuals with bipolar disorder reacted to stress. These investigators found that people who scored high on tests of introversion and obsessionality tended to relapse more often than people with low scores on these same tests. The personality traits of introversion and obsessionality have been shown in other studies to be strongly associated with anxiety disorders. It may be that early onset of anxiety contributes to the development of these personality characteristics. Post-traumatic stress disorder and social phobia, fear and avoidance of social performance situations in which the individual is exposed to evaluation by others or in which embarrassment may occur, have not been studied in bipolar illness. But it is likely that these also occur with elevated frequency and with negative consequences. People with bipolar disorder may have traumatic experiences during manic episodes. And for some people the manic episode itself may be experienced as a trauma. Social phobic symptoms may be of special concern during depressive episodes. People with bipolar disorder may also have problems with substance abuse. We know that the use of alcohol and of other recreational drugs is associated with anxiety disorders. Panic attacks and anxiety occur frequently during alcohol and sedative withdrawal states. Withdrawal also can worsen an underlying anxiety disorder. Some people develop panic disorder during cocaine use, and the panic attacks persist for years after cocaine use has stopped. Several types of medication are helpful in treating panic disorder. These include some of the anti-anxiety medications and some anticonvulsants in addition to several different classes of antidepressants. The general strategy for treating panic disorder is to begin with an extremely low dose and raise it gradually until a therapeutic level is achieved. One study suggests that treatment of people who have both bipolar disorder and panic disorder is best accomplished using clonopin or possibly an anticonvulsant. Obsessive-compulsive disorder, OCD, can be treated successfully using either behavioral treatment or medication. A research has been done on the treatment of OCD when it occurs along with bipolar illness, so what follows is a summary of current clinical thinking about treating OCD in general. Serotonin-active medications seem to be most helpful in treating OCD. Antidepressants without serotonin activity are of no use at all. They show results similar to placebo in clinical trials. Anafranil was the first antidepressant medication approved for the treatment of OCD, and it is quite effective. However, current recommendations are to begin treatment with a more selective serotonin medication, such as Paxil, because there are fewer side effects. Of course, people who have bipolar disorder and take antidepressant medication also need to be taking a mood-stabilizing medication to lower the risk of triggering a manic episode. Social phobia has been less studied than other anxiety disorders in bipolar illness. Social phobia is more likely to occur during a depressive episode, while panic and OCD may occur at any time. The best studied medication for uncomplicated social phobia is the antidepressant Nadol, and MAO inhibitor. High-potency benzodiazepines, such as clonopin, have also been shown to be effective. And as with OCD and panic disorder, people with bipolar disorder and OCD who are taking antidepressants also should be taking mood stabilizers like lithium or anticonvulsants. Post-traumatic stress disorder, PTSD, is a recently recognized condition which may be much more common than was once thought. The symptoms of PTSD occur after a person has been exposed to a situation in which there has been a direct and serious threat to the person's life or body, or has witnessed a similar threat to another person. The individual experiencing or observing this situation feels a sense of intense horror and helplessness, followed by symptoms of re-experiencing the trauma in nightmares, flashbacks, memories, etc. A person who develops PTSD generally avoids reminders of the threatening situation. He or she may develop full-blown agoraphobia, may withdraw from other people, and may expect that the future will not hold much and that life will not last long. Also common are feeling emotionally numb and unresponsive to others after the incident. People also experience symptoms of increased arousal, such as startling easily, insomnia, difficulty concentrating and hypervigilance, scanning one's immediate area and trying to remain aware at all times of what is happening around one. PTSD has not been well studied in bipolar illness. However, since people with bipolar disorder often engage in risky behaviors when they are ill, it is likely that they may be exposed to life-threatening situations and that PTSD may also occur. Medication treatments for PTSD are less developed than that for other anxiety disorders. Anxiety disorders occur frequently. They are disabling conditions which often occur in addition to other illnesses. In particular, people with bipolar disorder also commonly have anxiety disorders. And when anxiety disorders are present, they may complicate treatment for bipolar disorder. Studies have shown that the co-occurrence of anxiety and mood disorders regularly leads to a poorer outcome. Therefore, it makes sense for clinicians treating people with bipolar disorder to attend to the possibility of the presence of a co-occurring anxiety disorder and to administer treatments known to be helpful for the specific anxiety disorder involved. Often pharmacological treatments, antidepressants, clonazepam and anticonvulsants, are similar to those already in use for treating the symptoms of bipolar disorder. However, the recommended starting doses and strategy for increasing medication may differ depending on which illness or illnesses are being treated. The presence of a clinically significant anxiety disorder may be a reason for adding clonazepam or other benzodiazepines, which otherwise would not be chosen. http://www.thebalancedmind.org/learn/library/anxiety-and-bipolar-disorder